So we're going to move on to our second plenary, From Global Commitments to Action, and I wanted to introduce our wonderful moderator, Rachel Nugent, who I don't think needs an introduction, but she's the affiliate associate professor at the University of Washington, and she served as the director of the Center for Global NCDs at RTI International until 2023. She's been a leading voice in global health and economics with over 30 years of experience advising governments, international organizations on NCD policy and financing. And we're also very lucky to have her on our IATA board. So over to you, Rachel, to introduce the panel.
Great. Thank you so much, Sylvia. Thank you, everyone, for inviting me to be here. And we'll get to the panelists here in a second. I just want to say that I was really glad that IATA didn't ask me to participate in the financing panel that you just heard, which was a fantastic panel. But I spent so many years explaining that I didn't know where those special pots of money were that people needed for NCDs. It was like, I'm sorry, I don't have the answer. But then I was asked to talk about global commitments and how to achieve global commitments. I thought, oh, that's even harder. So the panelists are going to tell us how we can achieve global commitments and get action. That's not an easy thing. And how we're going to do this is that each of our great panelists is going to, and we have one panelist that is going to be virtual, right? No, we're all here. Oh, okay, fantastic. Why did I think that? So we're going to, each panelist will have some comments, just as in the last panel, and then we'll have a little discussion up here. I have a few cogent, piercing questions for each of them, and then we'll come to the audience. So I think that without further ado, I'm going to say a few things here about our objectives. We're going to review recent global commitments, define priority areas, identify practical strategies. All the panelists have been asked to think hard about action and how to achieve action. So we want this to be very practical. And in preparation, I did a little bit of reading, because I'm retired, I don't do that much reading anymore. But I wanted to share, there is an article, hold on, give me a sec here. Mostly word searches, mostly crossword puzzles, you know how that goes. Now, an article published by lots of WHO officials in different regions and at headquarters about operationalizing health in the humanitarian development peace nexus. It's a mouthful, HDPN. This was focused on Africa, but it's applicable everywhere. And I wanted to just pull out a couple of sentences from that. It was published in BMJ Global Health in August. And I think it sort of highlights some things that have already come up here. And I'm going to sort of use it as a jumping off point to challenge our panelists a little bit. It basically is a very nice conceptual framework for operationalizing health. That is bringing health into the humanitarian development peace nexus, and that has been referred to already. And the current status here, this is what I wanted to kind of bring up and put fresh in our minds. They talk in the article about inadequate political support. That's not a surprise. Competition and cultural differences between humanitarian and development actors. These are hindrances to progress. And I think that's a good one to bring up here, because we did hear already about coordination, but competition is something that, we don't always speak about openly. But, well, I think someone did mention it earlier. But I think we should take it seriously in this, time of crisis that we're in. Cultural differences. Lack of control of the situation by national authorities. And then finally, and in particular, although health has been discussed in the HDPN literature, there's little evidence for its systematic consideration. So I think that's what we're here for. I think it's great that it's been called out. And I think we're here to talk about how to change that. Some of the people here are actively doing that. So that's kind of what's on my mind for us to achieve here. And with that, I'm going to briefly introduce people because the bios are online there. So let me just turn to that right place. And I guess we'll start with Araya. All right, Araya James is a consultant who works on the WHO Global Diabetes Compact, and she works on advocacy and communication to advance global diabetes care. Araya has an MSc in public health from the London School of Hygiene and Tropical Medicine and is a person living with type 1 diabetes. So she has a lot to say about this, and I'm going to introduce everybody and then come back to you, Araya, if you don't mind. Dr. Hisham El-Berry is a doctor, senior strategy and policy advisor, and officer in charge in Libya, WHO Libya. And Hisham has a lot of experience in NCDs and health system strengthening, and particularly he's been working on what do we call these? I guess policies and operational guidelines for NCDs, strategies, ways to get these things operationalized across the Eastern Mediterranean. So some really good progress there that I think is applicable elsewhere we'll hear about. Dr. Mahmoud Derwat, he also a doctor, a psychiatrist, and working in the NCD office at IFRC here in Geneva, brings clinical insights and as well as humanitarian knowledge working across the MENA and Africa regions. And then last but certainly not least, Alison Cox, who is with the NCD Alliance Policy and Advocacy Director. Alison has extensive experience in global health policy, particularly strong in the tobacco realm in her earlier life, but now you've been 8 years at NCDA? No. 3. Something here says 8 years, but yeah, 3, which probably feels like 8 years sometimes in the NCD advocacy. And we have some important questions to bring up to Alison about advocacy for NCDs, and particularly humanitarian settings. So you've heard from me plenty. Let me go back to Araya and turn over the floor to you. Thank you.
Thank you very much, Rachel. Hello, everybody. My name is Aurea James. I'm a consultant, as Rachel mentioned, with the Global Diabetes Compact, and I'm also living with type 1 diabetes. And today there were 2 things that I wanted to cover in my introduction. I want to talk to you a little bit about this political declaration that we have on our hands now that has been published. And I also want to talk to you a little bit about meaningful engagement and the importance and the necessity of having lived experience voices in the work that we do. But to start us off with a little bit of scene setting about the political declaration, we have this political declaration now, I think soon, hopefully, to be passed, to be endorsed. And one thing that I find really helpful when talking about next steps with regards to this political declaration is to first understand that this is not a legally binding document. This is not a document that has accountability mechanisms built into it. It's not an implementation plan, it's not an action plan, and that is one of the reasons why it is so important to talk about next steps, about accountability, and about implementation. But as you may know, the zero draft of this political declaration came out earlier this year in May. And this zero draft, or the first draft, was the output of inputs from a lot of different actors over many years. We had inputs from civil society organizations, non-governmental organizations, UN member states, UN agencies, and also people with lived experience. But at the point of publication of this zero draft, when it was publicly available in May, only member states could take it forward for negotiations. And I know sometimes there are questions or maybe a bit of confusion about what WHO's role was in this political declaration. And I can share that WHO had a technical advisory role. So we were here to ensure that what member states wanted included was technically correct, that it was evidence-informed, but we didn't have the power to dictate what was included and what was excluded. And I think that's just a bit of information that I wanted to share for clarity. But there were 2 bits of the political declaration that I thought I would highlight for us today, the commitment related to diabetes and then also the commitments related to humanitarian settings. There is one diabetes-specific commitment within this political declaration, and several things changed within it between the zero draft that we saw in May and the final draft or the near final draft that we see now. And one of the first things that happened is that insulin was taken out of this commitment. Insulin is no longer mentioned by name in this political declaration. And the second thing that happened is that the global diabetes coverage targets were also removed from this commitment. And if you're unfamiliar, the global diabetes coverage targets are 5 global targets to be achieved by year 2030 that were endorsed by WHO member states back in 2022. So these targets, they already exist. They're already endorsed. There's already work going on to try and meet these targets, but those targets were removed. And I know certainly I can speak, at least from the lived community or the lived experience community lens, that we really felt that this was a dilution of the strength of this commitment. We were really cautiously optimistic when we saw this zero draft with the insulin included, with the global diabetes coverage targets included, and we had high hopes for the way this target could be expanded and strengthened, and instead we have a situation now where it has actually subjectively perhaps been weakened or diluted. But on a slightly different, I think more optimistic point, the humanitarian setting related commitments, I feel, were really strengthened. So there were 3 humanitarian setting related commitments in the zero draft in May, and 5 humanitarian setting related commitments in the draft that we see now, this near final draft. Lovely, I have them here for you, but we have in our political declaration now the acknowledgement that humanitarian settings bear a disproportionate burden of NCDs, and also the fact that humanitarian crises and other intersecting crises have strained fiscal capacity. But very importantly, and I think something that we can celebrate, is the fact that our commitments now include highlighting continuity of care and access to care. We have a commitment about the integration of NCD services into humanitarian response frameworks, and we also have a commitment about the design and implementation of NCD policies in humanitarian settings. And another win that I want to celebrate here, we have gone from 3 to 5 this year in terms of commitments, but back in 2018 with the 3rd high-level meeting on NCDs, humanitarian settings were mentioned once in that political declaration. And back in 2014 and 2011 with the 1st and 2nd high-level meetings on NCDs, the political declaration and the outcomes document that came out of that didn't mention humanitarian settings at all. And so we are at least seeing a trend in terms of visibility, of increased visibility and advocacy, looking at this intersection of diabetes or NCDs and humanitarian settings. But while I have your attention on this very important slide with some very important sentences, I do have one more slide that I want to show you with slightly different sentences on it. These are some quotes taken from a paper I published last year about the experience of living with and managing type 1 diabetes in humanitarian settings. And there's a couple different reasons why I wanted to show you these quotes today. The first one is to help us remain grounded. I think sometimes in these conversations that we have about high-level meetings, high-level commitments, it can start to feel a bit divorced from reality. And I want us to have at front of our mind the challenges that people living with diabetes are going through every day across the world in different kinds of humanitarian settings. But the second reason that I wanted to showcase these quotes for you today is because I think they do an excellent job at showcasing the depth of information and the nuance and the complexity of information that you can get from people with lived experience of diabetes. These kinds of insights, you cannot and will not get it from quantitative data, will not get it from biomedical data. And not only are these insights helpful for understanding service provision and access to medicines, but they're also helpful for understanding key components of life and well-being and care, like social and cultural determinants or norms, power hierarchies that may be at play, logistical or implementation challenges that might be a bit hidden from view, and also things like stigma and misinformation. And I think that my time is almost up here, but I want to leave you with a couple takeaways. And the first thing is that lived experience insights, as well as processes like co-production, co-creation, shared decision-making, it is an asset to the design, to the implementation, and to the monitoring and evaluation of our programs. And lastly, I want to say that the meaningful engagement of people with type 1 diabetes, it is strategic, it is effective, and it is also necessary for meaningful change. And I'll leave it there.
Thank you, Oria, and apologies for mispronouncing your name earlier. Oria, everybody. Okay, Hisham, let's go directly to you, please.
Thank you very much. And yeah, I think she makes my intervention easier. I think it's, well, first of all, thank you very much, Ayada, for inviting me to this great discussion. And I really liked very much the title of this panel, because this is what all is about, is how we can move this commitment to actions. I'm working, as I mentioned, at the level of, at national level. I used to work at regional level. I know our in EMRO, let's say, and EMRO is really facing the most humanitarian, let's say, context with all countries facing these challenges. What I prepared, frankly speaking, here, it was mainly milestones that Bente, talked about. But I think it's worth noting that I will highlight some milestones. But let's agree that we all agree that there is now a high commitment to integrate NCDs, in preparedness and response plans and emergencies, and we have it at the highest level. We have this, I think, and how I can qualify the last UNGA high-level meeting is just, as I wrote here, this move NCDs from an optional extra to explicitly political priority. Now we have this priority. We have a lot of other milestones. I will also emphasize the World Health Assembly, mainly the 22 World Health Assembly. I think it was very, very important, to, let's say, call for strengthening NCD integration across the entire emergency cycle, preparedness, response, and resilience. The global and the regional technical meeting in Cairo in December 22, I think it was also what we call, it served as the global kick-off, bringing together all the other regions to discuss these NCDs in humanitarian settings. And especially, we heard from CRO, I think we need to mention this. CRO, which is the WHO Southeast Asia region, so they published a foundational guidance on the integration of NCDs in preparedness and response in 2018, and it was also, I think, a good milestone discussing NCDs in humanitarian settings, and I think it's really, really important to mention this. Then the global high-level technical meeting in Copenhagen, of course, in February 2024, where most of you, I think you were there, and I think it was also a huge milestone, and it's fed also the political declaration recommendation. So I think it's really important, to mention these milestones, and now we can say that we have this necessarily political license. We have it, but now how we can, put it, how we can, implement it at the level of regions and at national level. And this is, I think, the question and the challenges we are really facing, to implement or to put NCDs as a priority in the preparedness, response, and recovery plans and the strategies. This is the huge gap. And here where maybe the WHO EMRO regional framework for action, and I asked, I don't know if it's I think here, I don't know if everyone is aware about the resolution and the regional framework for action. Here when we can say that the regional framework for action has its own place, it's, well, it was a kind of request from the countries, even during this December 22 meeting, the global and regional meeting, how are we gonna address NCDs in a region like EMRO, which is facing, or half of the countries are, fragile countries. It was endorsed by 22 countries. Okay, so the whole countries, 100% of the countries in EMRO, and it's taking into consideration the whole cycle or emergency cycle, and it's based in 5 main domains. You have them in front of a few. It's a leadership, collaboration, and advocacy. It's money, it's funding, finance. I think it's very, very important, and I very much like the discussion this morning in the first panel, and it's one of the most important discussion. The service delivery, it's not only about the vial of insulin, but it's like sustainable service delivery. Here it's not like the other maybe communicable disease. We are talking about people living with their conditions 24/7. And sometimes even in the acute emergency, we are just thinking about the crisis. But here we are targeting population with the chronic diseases, which is very, very important. Community collaboration, but also how we can build trust. And this is something very, very important in countries, in humanitarian settings. Of course, information, data, which is really, really missing, really lacking. How we can, plan, how we can be in the preparedness plans, in the response plans, mainly acute response plans, without having any data, any information regarding the situation. So this is mainly what the regional framework is about. So its core function, this is the first one. But the second one is to strengthen the monitoring accountability. And I can say that with this regional framework for action, we can also track policy adoption. So so it was in 2023. So early this month, we had what we call the progress monitoring of the implementation of the regional framework for action with the 22 countries. And we are following with the countries at least, so how many member states have integrated, NCDs in their national preparedness and response plans, and supporting them, how they can implement this. So also to measure the service continuity, as I said, the availability, the accessibility of services, of drugs and the medicine, and to have this report progress. Maybe I can stop here, but yeah, I can talk more about the regional framework for action. Over to you.
Great, thank you. I will come back to you to ask more about the regional framework, but I think that example of a framework of how to look at the governance and the policies that emerge from good governance. I think the Emerald region has certainly shown us good leadership there, so we'll want to hear a little bit more about that. Hisham, thank you. But now we'll turn to Mahmoud and hear about collaboration and implementation.
Yeah, thank you so much, and thanks Sylvia and Iada for inviting IFSC to be part of this symposium and the panel. In regard to the point that I have been designated to answer it, in the beginning I thought it was a very difficult question to be answered from the IFRC perspective. I thought it should go for the WHO in terms of the coordination and implementation about all political declarations. But the thing that's I started to prepare what we already have on the table, and among of what we had. I went through that's from the IFRC perspective, as we are representing 191 Red Cross, Red Crescent national societies, and there are 17 million volunteers. That's we come up with a global mapping survey for the non-communicable disease across the entire network, and we find that we have 93 national societies are having and running NCD programs in different settings, either the community-based or primary healthcare, up to the higher level based on the capacity of the national societies. But the thing that's also, again, how we are also trying to see the milestones across that we reached to the last UN high-level meeting last month, and looking also to considering the EMRO framework 2021, and then the global high-level technical meeting in Denmark last year. And the year we had the Copenhagen conference, and also the IFRC Global Advocacy Bootcamp and the WHA. And so I said, wow, it's an excellent convening opportunities and platforms for all of others. But the outcomes of those documents, of those platforms, just only documents. And they are just stopping on the door of the ministries of health. They're not just moving forward. And what is the issue? And then we are struggling. That's what we are able to present for the policy makers and who are controlling the ability to push those documents and translate it into a field reality, into financing arms to be supporting the communities. And I see it's just not just only all those challenges. And also we have come up with like a strong, more than this, we have lived experience. We have also experience from local actors, civil societies, including our Red Cross, Red Crescent, national societies. But the challenge is how we translating this. We need to move from being convening to be more convergence on the realities. How we are convergent financing, knowledge, and field realities. And this is, I think, one of the most important questions that we need to think about and how we are moving this. And on the other elements also, that's how also we can think into accountabilities. Accountability, we also, in considering, in the policy ask for the bootcamp, we consider accountabilities. On the frameworks that we consider accountabilities. But majority of the accountabilities are coming from being implemented to the donors. And it is not just only this. I think accountability also should come from the communities themselves. Communities themselves to be accountable for us to being a delivery and the service delivery. And also for us also to be also for the cause and for the rivers. And think this kind of bi-directional accountability can help also to move forward and also a translating thing. And think those translation need to be in terms of evidence-based for the policymakers. They look for why they need to more invest in non-communicable disease in terms of allocating financial resources. The issue is that we are failed this to present the evidence. We lack the evidence. We have excellent experience from the lived experience, from those are implementing on the ground. But we fail to translate this into research and knowledge that can feed into the policymakers, that can ask them to push more resources to the communities. And also, another part also the innovation and how we also can link those kind of things together so that we can able to push things. And in different conflicts, we can see this. The first thing that they are not starting to discuss is how to build resilience. Then there is not an issue of money. Money is there, resources is there, but how we are trying to think about not just building blocks or roads after the conflict's done, but I think that's how we are also allocating resources for services, for insulin, for medication, for chemotherapy, for renal dialysis. So I think all of these kinds is still there because money is there, but we need to just thinking about how we are building our actions to be more community-centric, more knowledgeable, and more evidence-based. I'll stop here.
Perfect. Thank you so much, Mahmoud. And I'm going to come back to you in the Q&A to ask you if you can get specific about that, given all of the chapters that you have with NCD programs. I'd love to hear some specifics from some examples. Thank you. And Alison, now let's turn to you. Global advocacy, commitments to action. Where are we?
So it's a big question. And thanks also from me to IADA for this symposium. It's a really important conversation at a really important time. So already got so much out of the discussion, and I'd like to try and make some links between the conversation about financing and this commitments piece. And I've also been sort of scrambling because quite a lot of what I wanted to say about the political declaration, I think Benta set the scene and Aurea did a fantastic job of talking about what was in the political declaration itself. So, yeah, to take a step back then, yes, definitely there's been this momentum building. As you say, going back to the Cairo meeting, then on to the Copenhagen meeting, looking at NCDs in humanitarian settings. There was a little bit of a hiatus while we waited for that report to come out, but finally that's out there and we can use it, about the useful material in there. And then we've also seen, as you were saying, more language and more connection between NCDs and humanitarian settings in the political declaration. You've talked about some of the things that went missing in action. I just wanted to flag another one, or really underline that one of the things that we really appreciate about the political declaration is that it has a framework of targets in there. And for us, whatever our reservations or criticisms about the declaration, and we have some, the fact that governments have come together and recognized the need for accelerated action by setting a set of targets, the accelerator fast-track targets for fewer tobacco users, more people with hypertension management and more access to mental health care. And then these 5 tracer targets we see as really being this high-level government commitment to faster action. However, there was a target in the governance section for 80% of countries to have integrated NCDs and mental health into national preparedness and response frameworks. And that went at the last minute. And we were really disappointed to see that go. Our understanding about that was possibly that this was around caution around the pandemic treaty that had been so hard to get agreement on and had been such a fine balance to finally get across the line, that I think our understanding is that governments are very cautious about doing anything that would bring it into tension with that. But I think that's where we need to look to the pandemic treaty and what's in there. And there's another pandemic treaty meeting next year in New York, and where we can see those links, because this point about healthier populations, stronger health systems, and more continuity in health systems is actually absolutely key to better responses and better resilience to future pandemics, because as we know, people living with NCDs are so vulnerable in these situations. So what else? So looking at my notes here, so the pandemic treaty includes some references to maintaining health services during emergencies, but it doesn't explicitly mention NCDs or chronic care, and Lord knows we tried. But so it's really important that we keep going, making those connections. Then moving on, where were we at with the political declaration? So yes, it's not a legally binding accord or treaty, but the reason we care so much about these high-level meetings and their declarations is this setting of political declaration and recommitment. And we saw that at the meeting. And what we want to do is build on that. And the line we're using is seeing it as a ceiling, as a floor, not the ceiling for what can be achieved. And we need to go back to governments in country and use it as a hook, as you were saying, and as a permission slip to have those conversations. You talked about this, you've agreed this in the negotiations. How are you going to deliver it in reality? I'm hesitating on this bit. So far, thanks to the US being somewhat difficult about the whole process, and we think using it as a political tool rather than addressing a really serious health emergency. They're using it as an opportunity to score political points against the WHO and the UN. Unfortunately, they've withheld their agreement to the declaration and are saying, making a process complaint about that and saying without their agreement, they don't, the President of the General Assembly doesn't have consensus, and therefore there's a process problem. However, the PGA, President of the General Assembly, said that there was broad support. Oh my Lord, am I at that point already? Broad support, and therefore that it was moving forward. So our expectation is still that this will go forward and will get adopted in the UN. We're still waiting for it to end up on the agenda at the UN General Assembly, but we're still firmly expecting that to happen. And that's where we need governments to us as civil society to be going back to government. So I want to quickly come back to your point about accountability. The example I was going to use is the Eastern Mediterranean NCD Alliance, who have been doing fantastic work and being really engaged. They've run their own regional conference, or co-hosted it anyway, integrating NCD care in humanitarian response in the Middle East. They've developed their own priority agenda for NCD care, of which of the 4 priorities, humanitarian care is the key one. And they've also developed a shadow report, to your point about accountability. So they've looked at the data across the different governments and produced their own shadow report, and using that as a way to engage governments and have conversations. So really good to see that sort of level of accountability coming from them. So I've run out of time on this one, but I have a lot to say about financing, so I'm hoping my follow-up question will take me there.
Oh, I think we'll bring up financing. Yes, don't worry. Thank you, Allison. Thank you to the whole, you guys were extraordinary, guys and gals, were extraordinary in keeping to time. So we have good time for discussions, and I'm going to deviate from script a little bit, as I do, and just pick up on, I think, Allison and Oria's points about global commitments, you know, what they mean, where we are. I just want to kind of underscore some of this, and then we'll maybe come back to it with your own questions. I was accused by a dear friend of being pathologically optimistic, but when I began discussing with the panelists here about this topic and what we would hear from them in this session, I wasn't feeling pathologically optimistic, and yet I think I'm hearing from you a more glass half full reaction and tenor. So I just want to kind of pose it as a question, maybe Oria, you first, and then Allison, and then Hisham and Mahmoud, if you want to comment on what anybody else has said or your own, sort of like, what in particular, a specific thing that is making you feel optimistic about moving global commitment into action, just to kind of put a point on this issue. Oria?
Thanks, Rachel. I hope it's okay. I'm going to bring up 3 things rather than 1. And it's the things that we see in this political declaration that we haven't seen in previous ones that really bring my optimism to the forefront. And one of them, as I discussed earlier, it has to do with the increased visibility of humanitarian settings. I think that, and as Allison said, this is a floor and not a ceiling, but the fact that we have specific actionable commitments now across many different commitments relating to humanitarian settings, I think that that is a cause for cautious optimism. The fact that member states, through a very rigorous negotiation process, didn't take out commitments. Instead, they actually ended up adding commitments. And of course, there was potentially a bit of dilution that occurred, a little bit of deletion, but we have humanitarian setting advocacy throughout this political declaration. And the 2 other areas that I think bring me a lot of optimism, for the first time ever within this political declaration, we have a specific commitment about the meaningful engagement of people with lived experience. We have a commitment now that actively identifies the fact that people with lived experience and their caregivers and their families have kind of unique experiences as well as firsthand expertise to contribute to the design, the implementation, and to the monitoring and evaluation of targets. And I think, again, that's an incredible floor that we now have the opportunity to build off of. It is still a floor, right? We're not among the, what is it? We're not exactly shooting for the moon necessarily with the wording as it is, but I think that we can take this as a sign of increased acknowledgement of where we can go from here and what is important. And then finally, I know this was discussed, but the fact that we have concrete targets within this political declaration, something that is going to aid in transparency and accountability as we move forward, that also brings me optimism for what is to come next. And hopefully by 2031, with our next meeting, we'll be able to look back at the last 6 years and, you know, have a good understanding of what we did, how we did it, and how we can continue to move forward.
Wonderful. I'm starting to be convinced. Allison, something to add?
So yeah, I'm sort of on the cusp there of the empty and or full. So there's 2 things I wanted to mention. One, I was really encouraged by what we heard on this session earlier about the global funds. And to give an example, in the previous high-level meeting on AIDS, it set a target, which included a target for 90% of people living with HIV/AIDS having access to integrated care. And that was then turned into a commitment within the funding call, the last funding call, that gave governments an opportunity to include a budget line on integrated care. And I was really curious to see if anything ever happened with that, and we have been trying to find out whether or not any money flowed. And we worked with WHO colleagues trying to promote this out to NCD parts of government, ministries of health, because they're not the same people, the people writing the grants to the Global Fund and the people managing the NCD budgets, to try and get them to engage. So it was really encouraging to hear about that $500 million going forward, which, we worked out was around 5% of the total budget, which isn't huge, but it's a big increase on what would have gone previously. So that in itself is encouraging, although now we're living in this constrained time, so who knows what's going to happen next. And that's maybe, again, I'll talk in a minute about global health architecture. So that's one clear place for optimism, I think, that even the Global Fund is working towards some integrated approach, but I'd love to say more about that.
Thank you. Finally, the Global Fund, should we say it that way? Hisham, do you want to add to this cautious optimism theme?
I think what have been said is very, very important. I would say that we should be optimistic. We have to. I think this is very important. And why? Because we have, let's say, the know-how and the knowledge I think we are working on, we are learning, every day we are learning more and more about what's going on. And now we are convinced that, for example, NCDs should be part of, NCD preparedness and response and recovery plans. I think definitely we know how and we have this knowledge now. We have the actors. So actors exist. There are many stakeholders working on NCDs in emergencies. All what we need is this collaboration. We need to collaborate together, how we can work together, and we need to learn. We are not competing at the end of the day. So funds, I think we do have funds. I'm working at the level of the country, and I can see that there are funds, but it's fragmented. Sometimes the same agencies are duplicating work when other areas are completely neglected. I think we need just to rethink the way we are working. And I wanted to say that we need to have this, or we must move from this top-down approach. I think we need to think from a country perspective. And believe me, countries are not similar. If we look at Yemen, if we look at Libya, if we look at Syria, the context is different. So even if we have tools, we need to, do this effort, how we can adapt them. So I'm optimistic because we have everything, but still we need to work and learn how we can work together.
That's a really nice statement of both challenges and reason to be optimistic. I appreciate it. And a very nice segue, Mahmoud, to you and the issue of coordination, reduction of fragmentation. We heard about that somewhat in the first panel. And again, I was going to push you a little more for examples from some of the programs that you mentioned. You have a lot. ICRC has a lot. Sorry.
Yeah, thank you so much. I think ICRC colleagues, Sigi is joining there. We are at the IFRC, and somehow it's a complicated relationship between people can understand who's the IFRC, who's the ICRC. So I might just take IFRC. We are the membership for the Red Cross, Red Crescent national societies, the 191 national societies, and I think it's linked also to being the what's Hisham had been mentioning about the political declaration and go down on the country's level. And this is part of how the political declarations can open actually the door for the country level implementation and work, and how we are convening from the global to local, where the national societies, by their mandate with the government from Geneva Convention, have their auxiliary rule status, and which is something unique for the Red Cross, Red Crescent in their country. And this can open the door how they can work together with the ministries of health and pushing things. And it's also the declaration. It's also aligned with the IFRC Vision Framework 2030. Somehow, it's what we are missing is more into the alignment at the country level. And here, alignment as stakeholders, and I think that WHO can push this together, where we can sit on the country level with the ministries of health, and also from our side at the Red Cross national societies. But also not just only stop there, because also there is other actors that actually do a marvelous job on the ground. And I think those are most importantly to be on the center together with the lived experience. So we have this good example from the Syria Red Crescent national societies. Among the earthquake in 2023, their operational emergency response framework have been already including non-communicable disease because they have witnessed this experience for a decade. So they already learned from this experience. So that's when they started to prepare their emergency response plan for the earthquake. They already included the non-communicable disease. But this is just only as an example. And how we would like to replicate such models in different contexts and also to match the context specific for each of countries. But again, it's emphasizing on the alignment and how we are ensure coordination on the country level. As we are convening here at the global level, we need to replicate a model that can be successful in different contexts, that can building alignment between the different stakeholders.
Great, thank you so much. A question, I'm going to go back to Aurea for a little bit more commentary on the lived experience, in particular, as someone who is very deeply involved with lived experience communities and dialogue. What are you hearing in that community in terms of reaction to the final declaration, the status of it, and maybe even how the Global Diabetes Compact is incorporating people's experiences and responses? And then Alison, I'm going to come back to you for architecture. And then we're going to turn to the whole group.
Thanks, Rachel. I think that the first thing that I want to say is that the lived experience communities, we don't have one response to the political declaration. I know that I've heard conversations of people that feel real frustration. And I think that there has been, from some angles, a real loss of opportunity, perhaps particularly as it relates to the diabetes target. The fact that we don't have insulin in this political declaration, the fact that we don't have the global diabetes coverage targets, it is a shame that those were taken out. And not only that, that other things were not included. I know there was a real push, a hope that type 1 diabetes, for instance, might be included in that target, and it wasn't. But on the flip side of that, I think that there are many, many people that hold a real sense. We've just talked about cautious optimism, and that is definitely a sentiment that's shared in the lived experience communities as well. I think there is a lot of excitement specifically about the commitment related to meaningful engagement of people with lived experience. It's not the strongest commitment per se. I think that there's always an argument that the wording could have been stronger, but we now have explicitly in word the fact that people with lived experience and their caregivers and their family members have expertise, firsthand expertise, to be able to contribute to the design, the implementation, and to the monitoring and evaluation of our programs. But I also want to say kind of a sentence or two about the lived experience communities that I'm not a part of. And I'm thinking particularly about the millions and millions of people living with diabetes and other NCDs who have never heard of this political declaration and who have never heard about the high-level meeting on NCDs. I know earlier Bente in her introduction, she talked about the fact that we all have a role to play and that there's probably more that we can be doing in the realm of advocacy. And I think the fact that we haven't further invested in global health communications about these high-level meetings to a general public is a missed opportunity. I know that some people in response to that idea, they say the political declaration is a political document made for and by member states. But to that I say, who is this political declaration for? Whose lives are we trying to change? And if people living with NCDs are the lives that we're going to change, surely they're also a target audience that we ought to be targeting with our communications. And I think if more people with lived experience were involved in this process, the political declaration itself wouldn't necessarily have changed. That was a negotiation process by member states. But when we talk now about action and accountability and talking to our member state governments to push for meaningful change, what would it look like if we had twice the number of people with lived experience doing this advocacy, or 5 times, or 10 times, or 100 times? I think that we should be thinking bigger about what engagement looks like and thinking bigger about what the global advocacy scene can be like. And to answer your last question about what the Global Diabetes Compact is doing, there are several ways that we're aiming to better integrate, systematically integrate lived experience voices into our work. And I will be the first to say that what we do isn't perfect. It's not necessarily the best way to move forward, but we are trying really hard to effectively integrate lived experience voices into our decision making, into our prioritization settings. And for instance, we hold annual meetings specifically on the engagement of people with lived experience of diabetes to do things like feedback into our technical products and into our initiatives. So we had an event earlier this year where people living with diabetes from all 6 WHO regions had an opportunity to feedback into the WHO Therapeutic Patient Education Program. And something else that we do, we have an incredible forum. The Global Diabetes Compact Forum is a group of more than 150 member organizations, and we get together twice a year to share information and to talk about global advocacy. And for those meetings that we hold online, we always try and have people with lived experience be moderators, so that lived experience insights and lenses can be shared with the greatest number of people. I think that I see Mohammed sitting in the second row there. I moderated a forum meeting with Mohammed just last week, as it happens, about the political declaration, a very topical topic. But that's another way that we're integrating lived experience. We have a technical advisory group on diabetes, a group that's external to WHO that helps us, do our priority setting and our strategy setting, and there's lived experience within that group as well. And I think we could also say we hire people with lived experience of diabetes. I myself live with diabetes. We have other people on the team with lived experience. And as one last note, Diabetes Awareness Month is on the horizon. We are hard at work right now with all our Diabetes Awareness Month campaign materials, and the graphic designer that we have used for more than 3 years now also lives with diabetes. So these are a couple of the different ways, and I hope this is helpful, specific context for the ways that we're moving forward with integrating lived experience. Like I said, there's more that we can do, and we are working to be more systematic and more effective. But I did want to share those examples with you all today.
Thank you, Oria. Those are really fabulous examples and very, very encouraging and very specific too. So thank you for that. I know, Allison, you could talk a lot about engaging people with lived experience and how to use that in global advocacy and connect it to commitments. But I'm going to ask you a slightly different question now. This may be from sublime to ridiculous, but the ridiculous is the big picture question of global health architecture. This was something that Allison has recently been thinking about, talking about with people, and I think it's worth bringing up in our discussion, even though it's not necessarily directly germane to global commitments, but it's germane to what is global health for and how to achieve the goals and meet people's needs, and give us a few thoughts on that and maybe some action items.
I'll do my best, and I'll also come back to engaging lived experience because I think it's key. Yeah, I was saying to you in the break, I've just come back from the World Health Summit, and just after that I managed to wangle my way into a consultation about the future of global health architecture. And there were all sorts of people in the room, Gavi and the Global Fund and government funders. And I was saying I'm still processing what that's about. So I'm still working that through, so bear with me. I'm going to try and do some externalizing of that. And the first thing to say is always follow the money. That's always been a guiding principle for me about advocacy. Like, where is the money flowing? And when the NCD Alliance was set up in the first place, and I was around back in the day, one of the big founding things was NCDs had been left out of the Millennium Development Goals. They'd been very consciously left out of the Millennium Development Goals, and we'd been left out of the funding that flowed from those goals. So we were left out of the architecture that was set up. And so the big founding federations, lung cancer, heart and diabetes, came together and said, we've got to join forces and try and get our mainstream diseases onto the agenda. And so the means, rather than the end, was to get a high-level meeting. It wasn't the end to get a high-level meeting. It was something we thought would help us move along. And at that point, the only health high-level meeting that had happened before had been 10 years earlier and had been on HIV/AIDS. And we thought, well, look what happened there. They had a high-level meeting, see what happened. And we thought, getting our summit in New York would help that to happen. 14, 15 years later, we're still only getting less than 2% of development assistance for health. So that we didn't think we'd get our own pillar or our own vertical, but we want to be integrated. So important, though, having a fourth high-level meeting is, and important, though, that renewed commitment, and it has been really important to get governments talking about NCDs again. We're getting meetings that we weren't getting 2 years ago because there's been a summit. We've had governments having to talk about it. It is really important. But I have to say, coming out of that and then going to these places where the conversation about the future of global health architecture is happening, this response to these huge cuts that's come, particularly from the US, but as was said earlier, not only from the US. There's these conversations happening, and we have to engage with those. We have to work out how to get in there. And what really struck me about the meeting I was in yesterday is the existing global health architecture are having a conversation about the future of health architecture, and we're still not really in the room. And to give an example of how that conversation went, we were in working groups yesterday, and it comes back to the story about the pandemic. Governments are very concerned about future health emergencies and the threat of future pandemics. They see this as a real thing that governments need to address. And we were in, one of the breakout groups was on innovation and access. And so the real focus was on what do we do about new intellectual property and sharing that, and what a big issue that had been during the pandemic. And how do we make sure the whole world has access to that? And I was saying, well, we've had insulin for 100 years, but still less than half the people who need it have access to it. Am I in the right working group for that conversation? Where's that conversation? And it was a really difficult thing to keep coming back to it and go, no, that's really interesting about that new global health threat, but what about this existing global health threat that's been around? And it really, I had to keep saying it a little bit, but I don't know if it dropped the penny, but we tried. And that's what I've come back into this room to say. We really need to get in there right now and talk to the funders, as the Global Fund and Gavi and so on, they are the structures for delivery, but we need to be getting to the governments again and saying about how we need to be integrated into this conversation. And come back, the Global Burden of Disease report came out on Monday, making the case so clearly about the burden of disease of NCDs, diabetes, obesity, huge figures about how this is a threat. But it's like we're there but not seen. So the same problem exists. So I'm getting a little bit shouty again. This is what I found myself yesterday, getting a bit shouty. So but we have to work out our strategy. And I heard people talking about the advocacy. Oh, what was marvelous about the HIV/AIDS movement was that there was the advocacy. Again, like we don't exist, like we aren't making that advocacy. So we have to get out there and really make the demand and be seen in this discussion.
Thank you. That is, well, I don't know if it's deja vu all over again or if it's a really important call to action, but those discussions are happening amongst important people and institutions, and thank you, Alison, for being there, for pushing your way into the door, and we have to keep on figuring out how to do that. Let us, first of all, we won't thank the panelists yet. We're not going to let them off the hook yet, but let's turn to you all. I'm going to start with Mohammed, and then look to everybody else. And Mohammed, not to put you on the spot, but my colleague Mohammed Sayed, who works with IATA and had the pleasure of getting to know as an advocate for people living with diabetes. I wanted to hear your reflections first on maybe the discussion here, but also where we stand in terms of global commitments and action, please.
Yeah, well, to be honest, a fantastic panel, very insightful discussions, of course, and I loved every part of it. Where to start? Well, to be honest, when it comes to kind of reflecting on those commitments, I think on meaningful engagement, definitely very positive. It's a step forward. Again, just a step forward. We still have a lot to do all together, all different stakeholders. And we all love the term, I guess. Meaningful engagement is big. We all love it. We want to hear it all the time. But most of the time when we reach to, let's say, to the point where we're at a country level or a government level, local level, we don't know what to do. We think that, oh, let's just get this person living with diabetes on a panel. Let's include them in the, in the appendix and in the document that I'm writing. But there isn't an actual metric of how to do it. And this kind of leaves the door open for governments. Well, they've seen that they needed to recognize lived experience as a lived experience in the political declaration, but it leaves the door open for them on how to do it, and I'm going to do it the way I want to do it, the way I think I should do it, without actually, potentially, without reflecting on the needs of the population, the needs of those living with diabetes. So I think that is something that we should reflect on. The second thing, on point of accountability, we want to be accountable, but again, lovely to hear from the panel that we want to involve those living with non-communicable diseases and diabetes here into how we do accountability. And of course, that also includes at government level, at governing bodies levels. Why don't we advocate for ministries of health to have their own panel reviews or progress review reports that include people living with diabetes and how we make the decisions and what are the targets that we want to meet. I think that is an important point that we could move forward with, because at the global level, of course, we all want this. We do it at different organizations, different parties, but then at the local actual level where implementation is, we lack that. And we find that people living with non-communicable diseases, here diabetes, tend to forget about the governing body, the health systems there, and probably go to civil society organizations that open the door for them. And I think this also fragments the services a little bit. Of course, we recognize and value the role of civil society organizations. We need them. As a person living with diabetes, this is how I started my advocacy work. But it's also very important to do this in parallel with how we do it with local health systems. How can we include civil society organizations and people living with diabetes, working with civil society organizations and hopefully working with government to kind of create that kind of unfragmented. And I'm going to keep using the word fragmented because this is what we're seeing in the humanitarian health science at the moment. So that's the big issue, I think, in when it comes to actions. But yeah, very, very, very positive, of course, that we're seeing the commitment going ahead. But of course, a lot of work that we need to do. There's so much focus on what is the problem, what is the problem, what is the problem, but less binding focus on, well, first, why is it a problem? And then after the what, how to actually solve the problem. Because, like for example, when it comes to funding, and we were saying that we want to focus on NCDs and fund NCDs. We want more data on NCDs. Well, Alison just mentioned that we have data on NCDs. Maybe not enough, but we have data on NCDs. But I think there are some kind of political biases and short-sighted political decisions that are made at government level, governing bodies level, that kind of intercept the way how we fund NCDs and how we should focus on NCDs. We know that NCDs or diabetes, well, that doesn't wait in a crisis. People living with diabetes could literally lose their lives if they don't have access to insulin. We all know this, governments know this, but we don't see the action. So again, to the question, why? And then how all of us together can do this as stakeholders. I think this would be very important. But yes, I'm also a very optimistic person. I think, yeah, we used to not hear these kind of discussions 2 decades ago. Now we're hearing them openly. We're including people with lived experience in decision making. Yes, they're a little bit underrepresented, but I think we're going there. And there's so much to actually do. So hopefully all of us together can proceed with that.
Excellent, thank you. So maybe we're all in this room because we're optimists, perhaps. We have that in common. So I'm gonna go to the back there and I'm gonna just remind people, Mohammed said the how, okay? The how of getting past some of these obstacles that have been discussed. That's always good to hear people give us some guidance. So yeah, if you would introduce yourself first and then go ahead with your question, direct it to whomever you like or just in general, please.
Sure. Ahmed Al-Nasser, Diabetes Education for All. I wanted to really commend the panelists as well as Sylvia and kind of Ayada for, I think we're all seeing the general vision as to kind of how the conference is coming about. If you know, from my perspective, it seemed like the introductions were all developed in conjunction with one another, as based on how they were all, you know, very well complemented one another in terms of very strategic framework. So I just wanted to say that initially. But one of the things that really stood out to me from Oria's presentation was kind of in the, you know, without the insulin commitments, the importance of, you know, what we're calling life experiences, that being the importance of open access education with respect to being able to formalize just general knowledge, baseline knowledge, sharing of information, insulin switching guides, whatever you want to kind of speak to it as. I think that was really important, especially with the, you know, with the removal of the insulin commitments. In terms of what Dr. Elberry was saying regarding kind of the dealing with kind of national bodies. And from my perspective, it seems like, you know, the actual presence of a proof of concept is really important when dealing with governmental national bodies, such that you're providing them with some understanding of an actual solution, as opposed to coming into that framework or that working group with, you know, at step 0 or step 1, such that there's some buy-in that you can accomplish with those national bodies, such that they feel, if there's kind of a, you know, if their decision makers are non-medical professionals, they feel like they can maybe kind of trust kind of what's going forward. And I think that's kind of really interesting that I had seen in regards to what was spoken about with the communication and collaboration. I think, you know, the establishment of, you know, having an established framework, whether it's EPAs or whatever the case you're working in, is really important, such that you know, people can come in and feel more comfortable with collaborating and having an expected, you know, roles in the process going forward, as opposed to people maybe competing with one another in a way that maybe creates a more less constructive outcome to what's being worked on.
Thank you. Is there a specific question for one
Yeah,
of the panelists?
Do you think, with all this stuff coming through, do you think maybe we need to talk about humanitarian settings in a more compartmentalized manner, such that we're not just speaking about it as it's a one size fits all? For instance, if you think about it, you know, for a nation like Armenia, for instance, it has a lot of buy-in, but there's a lot of, it's a very nascent educational kind of educational knowledge of what diabetes is and how to treat it. You know, it's very decentralized in terms of the rural regions. If you look at maybe some of these other places that are maybe impacted by strife and war and conflict, they're very highly educated populations, but there's a lack of resourcing. And, you know, as kind of was mentioned with Yemen and Syria, those are, you know, decentralized governments where maybe there is an access to more information, more resourcing and so on, but it's generally, you know, you have competing interests, such that, you know, there isn't an understanding of what framework to move forward with or what works, and so it's a lot of more resources, but lack of information.
Thank you. So how to contextualize and target access to information, diabetes information. Well, I'll take a couple more questions and then come back to the panel. I think.
Hi,
yeah.
it's James. And
James, hi.
this year I can definitely say I don't represent the WHO, but nice to see Oria and the team again. So I am with Voices in Action, People Living with Diabetes and Global Health, a new but growing NGO based in Canada. Also a person living with type 1 diabetes myself. I have a specific question, probably most for Allison, but if anyone knows the answer. So we look at draft 0, and we had the global diabetes coverage targets. We had mention of insulin. I think we also had mention of type 1 diabetes, and it's 10 pages. We look at the final draft. We have 15 pages, but all that got cut. And I talked to the Canadian mission, and they said in the negotiation process, it was really just a process of streamlining, but we grew by 50%, but we lost our targets, and we lost, in our community, the type 1 community, the most important part of the document, while the actual meeting itself was opened by a very graphic and heart-wrenching story of a girl nearly dying of type 1 diabetes in Zimbabwe, but the document didn't have the word type 1 diabetes. So my question for Allison is, where did it get cut and by whom?
Thank you for the specificity of that question, James. I think Allison can take that on. Yes, with the red sweater there. Whoops, Anna, sorry. We can't hear you, I think. Oh, one sec. They're turning you on.
Hello. Hi, everybody. Lovely panel. Thank you very much. I'm Shivani from ELRA, and I've met a lot of you, and you'll have heard about our project documenting innovations for cardiometabolic disease in humanitarian settings. And through that project, we found that there are some really great community-driven innovations happening. And I suppose documenting them and having them in one place is a first step. But my question to anyone who can answer is, how can we get those amazing innovations that are real commitments and actions to the commitments move forward in their journey to scale?
Oh, the core of our panel. Thank you, Shivali. One more question, and we'll go to the panel, and then we'll come back. I think we'll have time to come back for any others, but any other hands? Yeah, yes, right in the middle. And then, Anna, you're going to let me know if there's anyone online. Okay. Yes, please.
Hi, everyone. Thank you so much for this panel. I think it was very informative, very good. I'm excited for the answers to all the questions. My name is Chris Taves. I work for T1 International. And I'm just noticing a pretty big tension as this panel has gone on. And I think it's between the funding and then also including patients with lived experience. And I think earlier we had a question for transparency with funding sources. And then Allison, you mentioned like for advocacy, always follow the money. But a lot of times that money doesn't have a clear source, or maybe sources that patients with lived experience don't agree with. So how, and this can be for anyone on the panel, but how do you see moving forward to work around this tension of patients with lived experience being involved in these conversations and getting the funding and understanding how we can work out that transparency for better advocacy, better inclusion moving forward?
Great, thank you. Okay, let's turn to the panel. Maybe we'll start with the question at the beginning about education and contextualizing and targeting education for diabetes. And I thought maybe Hisham Mahmoud, maybe both of you would have a comment on that. Anybody else, of course?
Yeah, thank you, thank you. Very complex questions, frankly speaking. It's not easy, of course. So, I'm thinking from where I should start, because a lot of questions, and for sure, I have this, quotes from the film. I think it's very important. At the end of the day, in the film, I like very much. It says, no insulin, no home, no peace. I think, and you can think about insulin, compared to maybe home and peace, and I think it's very strong message. Basic medicines are as a human right, and not having insulin is an emergency. And I think this is the reality. Let's be frank. If we are focusing on the humanitarian settings, yes, it's nice. It's very beautiful. We have commitment. We have a global commitment. Now, how we can maybe move it to impact, to actions at the level of the countries, I think I wouldn't say there is one or one size fits all, or there is one manner, how to put it. But again, I think from the discussion, and that maybe it's just a small opinion, as I said, and it was said also, I think from the audience, moving from what Mohammed said, it's very, very important, and maybe other colleagues. People living with diabetes should be involved, definitely. So civil society should be involved, definitely. I like this, nothing for us without us. I think this is something really, really important. Sorry? It's the reality. Yeah, it's, yeah, it is. So I think it's something. But let's say something. So we need to think, and I find the solution in what we call the model of care. Which kind of model of care we need for diabetes people, for people living with NCDs at the level of the country? And this is, I don't think it's an easy question, because when we're talking about which model of care involving patient living with NCDs means that this should be tailored to each context. And when I talked about Libya, for example, we have 2 governments, and under each government, the Ministry of Health is not representing the health sectors. So primary health care is an entity, Ministry of Health is an entity. The emergency or department is another entity, which are not under the same, or let's say, ministries of health. So there are a lot of challenges, and I think we need to contextualize this, how we're gonna target, how we can prevent, how we're gonna control diabetes, NCDs. I think we need to contextualize this. So this is, when we talked about, for example, funding, transparency, yes, I totally agree. This is something I think we need to think about it from all levels, from the global, from the regional, but also from the national context. I know that I'm not getting to but I know that there are a lot of challenges to the answer directly, but what you have said, I think it's the reality. This is the context. I'm not saying that things are easy. I think we all need to brainstorm. I hope that tomorrow or during the working groups, we'll have some great recommendation from everyone how we're gonna tackle all these issues. But believe me, it's a very huge, yeah.
Thank you. Thank you. Mahmoud, do you want to comment on the question of contextualization?
Yes, I think it's also linked to the innovation where Shivani have been linked. And I think one of the start point is how we are addressing the education and also innovation as part of different perspective. What's fitting to the community and also what's fitting to the decision makers, because how this also can sustain the services on the ground, and the contextualization somehow is totally difficult from one context to other context. But at least what we can agree on is, and I think majority of the organizations here, everyone have their own frameworks that have also addressing this, but how translate it into reality, and linking also the culture itself, because when we are looking for the information, we are neglecting how the culture of people, how they are addressing, and the language itself. And if we were speaking here together as a non-communicable disease, I think people who are supporting us in the IT, they don't know what we are talking about. And this is actually the reality. So that I think language itself need to be considered, because we're speaking the same language at the global level and on this kind of the platform. But we need to consider those as well.
Yeah, that's a great point, that talking amongst ourselves doesn't always get us what we need. So we won't have too much opportunity to come back to the audience, so that'll be for the lunchtime. But I want to come to Oria and to Alison for the comments, the questions that came up about advocacy, etc. Oria, you want to go first? You're eager.
Sure, sorry. I was inspired, Mahmoud, by what you just said, and something popped to mind that I wanted to bring up that I think is relevant to many of the questions that were just asked, which of course covers several different topics. And I want to bring my communications and advocacy lens to the forefront and talk specifically about knowledge translation. You know, we had a great question about open access education, about contextualization, and I want to talk about knowledge translation. So this idea of getting the right information to the right people at the right time in the right way. And I think that we have an underinvestment, if you will, in knowledge translation. When we talk about healthcare or public health, we constantly prioritize and throw around terms like person-centered care, tailored care, meet people where they're at, culturally sensitive care. But when we think about communications and education, we don't always bring that same strategic framework to the forefront. We need tailored communications specifically for policymakers in a language that speaks to them, that hits their pain points, hits their passion points. And that information is going to look very different than mobilizing lived experience, the global advocacy scene. We need different language, to your comment, and we need to make sure that it's contextually relevant, that it's localized, and again, that it hits their pain points and their passion points. I think, frankly, we have the skills to do so. We know a lot of these frameworks for how to make things more strategic, more effective, more sustainable with regards to healthcare. And if we could do our due diligence in taking some of those learnings and applying it instead to communications, to advocacy, to education, I think that would move us really far forward in a lot of different perspectives.
Thank you. Alison, I'm going to give you the last word here.
To the direct question, who did it and how, we don't know. We weren't allowed in the room. This is one of the things which we have a bit of a challenge about. It was a closed government process, only for member states, with some technical assistance from WHO. We did our best to get hold of the documents as they went through their drafting rounds and to see where things happened. The only thing we know is, there was pushback on targets. The US in particular did not like anything that associated it with WHO, and WHO agreed things, so that may well be why the Global Compact peace targets went out, would be my guess. And with insulin, it's hard to know. It may just have been a thoughtless streamlining of a sentence. It could even be as simple as that. So we just weren't in the room, and we don't know, and that's one of the things we're saying, that this needs to be a more transparent process, because we also see the hands of health-harming industries all over these outcomes. So they might not have been in the room, but they were having influence. So yeah, it's a tricky one. But to end on more of an upbeat note, I think there was this question about following the money and people with lived experience. I'm not sure that I know exactly what the question was, but what I would say is to keep coming back to this one, that we need to make our voices heard and make the lived experience be a really important part of that voice in the advocacy. So I appreciate there's a difference between what the millions of people who don't know anything about high-level meetings, but they do know that they haven't got access to what they need to have access to, and we need to channel that need to the places, and that's people like us, is role to find a conduit for it.
Thank you. I think that gives me the perfect final point to make here as we wrap up, with my pioneer's hat on, to say one of the things that we didn't do years, actually decades ago, as the NCD movement started, was that kind of communication. We talked a lot amongst ourselves. We still have some tendency to do that, but I think the knowledge translation point, the points that Alison just made about communication, all of us in the room, taking up Bente's challenge, can say, what am I doing to make a difference on that front? And I think with NCD Alliance's leadership and others, we've made a lot of progress in that direction compared to earlier days, and we can continue to make progress. So that isn't maybe what we came to say exactly, but I think that's what has emerged for me as one of the most important points. Alison, you want to add?
Only to say the words, that emphasis on an alliance. There's a whole range of organizations who make the NCD Alliance work, so it's bringing all these voices together, stronger together.
Yeah, that's great. Thank you. So with that, all I need to do is thank the panelists. You guys and gals, were fantastic.
Thank you so much. That was so interesting. Lots to chew on over lunch. So we have lunch in a minute, 2 rooms down on the right. But before we go, we're going to take a group photo. So do not leave the room. Come on up, and we will. Can we please turn off the projector so it's not? And then after that, everyone can head for lunch. So thank you again.